Hi guys, this is John Adamson, the Rehab Documentation Guru, and I'm responding to an email I got from a lady by the name of Laura, who's an OTR, and I'm just going to read her um, email and then go over basically what she's looking for on this. So thank you, Laura, for this question. She said, "Hi, I took your documentation bootcamp course. I had a question regarding intervention documentation." So she's talking about skilled intervention documentation. "I am doing environmental training with the caregivers of the patient. The patient is non-participatory in therapy. It is all total assist. Takes two to transfer with a sliding board. He is globally aphasic, 90-year-old stroke with complete right hemiparesis and Cushing syndrome. Patient caregivers are in room with patient and myself to be trained. We already did hands-on transfer. Now I need to tell them how to bathe him in his bed with sponge bathe, because it is too dangerous to sit him in a chair as he pushes himself out of any chair, and he does nothing to assist. I also tell them that they need to change him in the bed and how to do it, as he will not tell anyone he has to go to the bathroom. I tell them that hopefully he will get to the point to where he can tell them he has to go and can sit upright, and then get him bedside commode and how to deal with it. Can I bill for this? As if so, and if so, what CPT would I use? I'm going to come back to that question in a minute. And if I cannot bill for this, how should I do family training in this instance? Thank you so much for your help. I am trying to get our facility to turn around how we document, as we've had 20 denials last year alone. So we have a lot to work on. Okay, so good questions. So first of all, let's talk about the clinical aspect of this patient. This is a 90-year-old patient. Now, I'm guessing the fact that this person made it to 90 means he's a pretty sturdy individual, but he's got complete right hemiparetic, well, very dense right hemiparetic. He's globally aphasic, and he's got Cushing syndrome. I'm going to guess his rehab potential is fairly low. I mean, I know that in the realm of neuroplasticity, constraint-induced therapy, there's a lot we can try to do with these patients. However, I'm going to guess if he makes progress, it's going to be extremely slow, and he's probably fairly complex, and that's probably based on his age. So I would probably say that we're not looking at a lot of improvement. So this young lady went to my course. We have three types of goals that we do for non-maintenance patients: improve impairments, compensate for impairments, environmental adaptation. So with him having balance issues, with him having global aphasia, with him being right hemiparetic, with him having Pusher syndrome, these are things we're going to have to address, obviously, but they're going to take a lot of time and effort. It's going to be very challenging. And so his progress is going to be extremely incremental. What I would say is the goals must really capture the very small increments we need to have this patient make in order to show that we are making reasonable progress. So this is not going to be a patient that's going to go from total dependent to, let's say, max assist even. They're going to probably make incremental gains, like partial turns in bed, and maybe if there's a way to quantify how much pushing's going on, incremental progress and decreasing that pushing. So he'll still require a lot of assistance sitting, but finding ways to quantify this is going to be a challenge. That's going to impact the I goals, the improvement of impairment goals. The fact that he's globally aphasic probably does not bode well for him doing compensation techniques. And so I'm going to assume, based on what she wrote, that that's probably not going to be the case. What she is describing, though, is what we'd call E, environmental adaptation, and that's involving the caregivers and the care. And she's talking about training the caregivers with the patient. That's totally viable treatment. That's something that can be counted. That's great. Now, what do you bill it under? Well, it purely depends on what you're training. So, for example, she's training on bathing and dressing. Well, and she's an OT. Well, that's a technique related to ADL retraining 97535. Now, technically, according to the definition, 97535 has to do with compensations learned to address a problem. But when Medicare talks about compensations, they do mean it more globally from both patient and caregiver. So they're delving into the environmental adaptation. So that would be appropriate. Now, if we're doing just purely transfers for the sake of doing transfers, then I would say you're probably more under 97530, which is treatment related to mobility concerns, more general mobility. So that's probably going to be billed under that. And then let me see, what else did she ask? And that's basically it. I mean, that's how I would handle it. What are you seeking to get the patient to do with caregivers will help you determine what you're billing. So if you're teaching them a home exercise program to do with the patient for range of motion, strength, coordination, and or endurance, that would be billed under therapeutic exercise. If you're training the caregiver to do balance types of activities, then that would fall under neuromuscular reeducation. So, or I should say training the caregivers to do that with the patient. So it just depends on exactly what you're doing and what you'd put it under in this case. But I just want to touch base one more time on the clinical. Eye goals are going to take a long time on this patient. Incremental progress is going to have to be captured with really well teased out goals to just have incremental jumps in progress, not whole changes in levels of assistance. Otherwise, it's going to look like we're not getting reasonable progress. C goals, probably out. E goals, this is what the majority of what she's talking about. And with environmental adaptation, the big thing you've got is a very limited frequency, intensity, and duration. Probably talking about 1 to 4 total treatments, depending on the complexity and probably the number of goals. There's a lot of things being worked on. I could probably argue this would take more than 4 visits to get them to safely and effectively do these things with this patient. Anyway, thank you, Laura, for your question, and I hope you found this video helpful. If you did, please hit like and subscribe if you haven't already, and have a great day. Take care.